Our speaker today is Dr. Steven Barrett. Dr. Barrett earned his DDS from Case Western, then served in the Navy. And then in 1991, he joined Greenberg Dental and Orthodontics, which is a private group practice now with over 80 locations in Florida. He's currently the clinical director and a senior partner with the group. He organizes the group's in-house continuing education programs. He lectures at dental schools, and he provides one-on-one mentorships for the doctors in the practice. His topic today is Smile Design Principles for Aesthetic Success.
So actually, I was on a webinar this morning and another lecturer, and they started with the same slide, start with the end in mind. And I think when you talk about aesthetics and smile design, you really want to take advantage of when you look at the patient from the very first time that you meet them as starting to assess where you want to go with this patient. And I think that's critical. So we're going to talk a lot about, when do you start your aesthetic analysis, right? For me, it's always when I first meet the patient. And a lot of times, whether you meet the patients in the waiting room, maybe you meet them at the front desk in the operatory, but I'm looking at the patients and I'm trying to assess, what is their smile like? What I see a lot of the doctors that I work with, and over my career, I've worked with thousands of doctors. A lot of doctors do their evaluations from behind the patient, and the patient's upside down. So it's really hard to evaluate a patient's aesthetics or things that you'd like to change or help you to create a vision if you're looking at them always in this position. And that's why a lot of today you'll hear me talk about the use of photography. But the first thing that I ask myself when I meet a patient is, do the teeth fit the face? And I think that everyone would agree that if we look at these patients, that these teeth don't fit. This is all dentistry that was done. So somewhere along the line, someone lost sight of what was going to look appropriate. So when you first meet a patient, I look at the global aesthetics. I look at their face. I look at how do the teeth fit within that face. We kind of narrow it down and look at the macro aesthetics and look at what's framed by the lips. Right? If we use the lips as the frame, what's within that frame? The micro aesthetics, as you start to look really closely at the teeth and you start to talk about shape and texture and color and contours. And then really a very important part is those pink aesthetics. And we look at the gingival tissue. And if we remove the teeth out of the equation, what would we do with that soft tissue to enhance our cases? So smile design is really a balance between function, which is obviously going to be important, and aesthetics. And a lot of people say, well, where do you start, right? How do you determine what's most important? I recently was listening to a webinar from Dr. Hornbrook. He has said this for a long time, that aesthetics drive the case, function finishes the case. And so I've always adhered to the belief that we start with aesthetics. And so where do you start when you talk about aesthetics? For me, in my practice every day and the doctors that I work with, it's really about understanding our patients' goals. And most importantly, it's about understanding their budget. We always try to work within that patient's budget to achieve the outcome, maybe phasing that treatment over a period of time. But I start with a series of photographs. These are the photographs that I take. And a lot of times you'll hear lectures and they'll talk about taking 20, 21, 18, a whole variety of photographs. And I'm not saying that that's not necessary, but initially I can do everything I need to do with these photographs. I may take some other ones later. And you're going to need to have either a good scan or a good set of study models as well. So this is Angel, and we're going to look at Angel throughout the webinar today at different phases until we get to her end result. You can see the photographs, full face, teeth retracted so I can see the edges of the lower incisors, lateral views, rest position. And the reason that we take photographs is because it really will help you to develop your mind's eye. I always say it's about creating a vision, but it's not only a vision for you to be able to see how teeth fit into someone's face, it's also that vision that you share with your patient and that ultimately you learn to share with the laboratory. So the photographs also will help you kind of make some decisions about your treatment. If anyone has taken a Dawson course, you're kind of used to these 4 Rs. Teeth are going to be restored. They're going to be reshaped. You're going to reposition them maybe with ortho, or maybe there is some resetting and an orthodontic procedure that needs to be done. But you're going to make some evaluations based on your photographs. You're also going to make some decisions about how are you going to move things, and are you going to have an orthodontist help you, a periodontist, or perhaps that oral surgeon. I always talk about vision first, and you'll see it on my slides and most of my programs, because I think it's very important that young doctors especially develop their vision of how they see teeth fitting in the face. We've all heard the saying, what came first, the chicken or the egg, right? I always say, what came first, a doctor's vision or their clinical skills? Over time, just through repetition, you prep enough teeth, you get some clinical skills. But if you never develop a vision on how to look at teeth and how they fit in the face, you really kind of become a one-tooth dentist your whole life. So vision, I think, is very critical for all doctors, but really early in their career. We're going to look at 9 factors today. And could you expand this list? Could you make this list 15 things or 12 things? Sure. I'm going to tell you the things that I use mostly, talk a little bit about how I use them for patients. So the first thing I always want to do, because I'm starting with aesthetics in mind, I want to establish the incisal edge position of the upper teeth. That's going to be paramount for me. If you determine the position of the central incisor, everything else falls into place. The laterals are balanced off the centrals. The canines are balanced off the laterals, and et cetera, as we move back through the arch. So let's start with the central incisor. And so what do I look at? How do I determine where an upper tooth, where is its correct position? I'm going to look at the rest position. I'm going to look at the lip line or the smile line. And I'm going to look at the labial contour of the tooth. I'm going to look at those 3 parameters for every single patient. And if I'm changing something, again, I'm going to look at these things, and this is where I'm going to start. And so most of us were taught, at least I was in dental school, that at rest, 1 to 3 millimeters of display was aesthetically pleasing. And I think that's pretty common that a lot of people still hear that. However, I think it's also common that if someone shows more than 3 millimeters, 4 or 5 millimeters, it can still be very aesthetically pleasing. And so the balance is when you're trying to find where do you put the position of the tooth, how much display should they have? One of the things to consider is the patient's age. And I think any of us who have practiced for a while know that you just can't arbitrarily make the teeth so long that they stick out underneath the upper lip. You have to balance that. And at least for the last 4 or 5 years, I've really seen a lot of lectures, a lot of patients move towards some plastic surgery, a lip lift procedure. Really, when someone has maybe, based on their age, they don't show a lot of display, and we can't just make the teeth as long as we want. Or pretty common now that people have fillers, and they use fillers over many, many years. It adds some weight to the lip, some elasticity. And so a lip procedure instantly allows more display without ever having to fix the teeth. Just something to think about. It's really common in lip augmentation procedures, right, for these to become more common, and really understanding how the lip plays an integral part of it. So that's kind of an aside that I just want you to think about. But if we go back to a patient, this is Kathleen, and you can see on Kathleen, we added some length to her teeth. Before and after, we added with veneers and some crowns on her about 2 millimeters of display. And if you look at her full face, you can see that we moved those teeth out a little bit facially, which naturally makes the teeth look a little bit longer. We'll talk about that when we look at the profile pictures. But you can see how dramatic it is when you change that for someone. So when I look at someone's rest position, I'm determining how much do they show at rest. If I want to add some length, how much am I going to add? And again, I'll show you some of the process. I'm also going to look at their smile line or their lip line. This is a picture of a patient of mine who lives in Chicago, and she sent me this cell phone picture because she's not able to get to Orlando where I am at the moment. But you can see how nicely her veneers follow her lower lip. And if you look at it close, she has a really full lip. Let's use that as a guide for that incisal edge position of our teeth. That would be critical. Because often we see patients and they have an asymmetrical smile. Whether it's upper lip or lower lip, it really occurs in about 30% of our patients. And so if I can't use the lower lip as a guide, I can still make a pleasing smile. And so I may be using the interpupillary line as a guide, or I may be using just a horizontal reference. And again, I'll show you that in a little bit, but we're not able to follow the lower lip. Other patients have a reverse smile. And as soon as you point this out to a patient, instantly they understand why they don't really like their smile. They don't really understand what's wrong with it until you show them. So those incisal edges work directly opposite of the lower lip. And if we change that and we add length to the upper teeth, and in this case it was just an enamelplasty on the lower, so whether it's done with ortho and repositioning the lower teeth, we can make a dramatic change in someone's smile. We just have to recognize what the problem is. And again, another patient, she has a little bit of a reverse smile line. We restore her teeth and instantly she shows more teeth. And now those incisal edges follow her lower lip very nicely. And it can be very dramatic. Other patients have a very flat incisal edge, right? There's no curvature with their lower lip. These are patients, as long as you have enough overjet, you're going to be able to add some length and correct that. So these are very easy fixes. Most of the time when I'm talking to my patients, I'm making these changes during our consultation chairside by doing a mock-up. I do chairside composite mock-ups. And in those cases, I'm adding length to the teeth. I'm measuring. I'm taking photographs of rest positions and smiles, and we're comparing them back and forth. You could also do this if you do a wax-up, but you want to be able to give the lab some specific instructions on what you're looking for in that wax-up. Now you bring the patient back and you can do a trial smile where they can evaluate the changes. When you look at the facial contour, facial teeth have distinct planes, and that third plane, that incisal edge plane, is very, very important to make sure that it's in the right position. Otherwise, patients will perceive that maybe the teeth are too long. When they're not really too long, they're just too flared out. So that incisal edge position is very important when we start to talk about function and those F and V sounds, and that incisal edge placed nicely on the vermilion border, right? And you really evaluate these horizontal and the vertical position of that incisal edge in your provisional phase. That's the beauty about, and I'm a big fan of biotemps from Glidewell custom provisionals, but having them dialed in and work this out in your provisionals, the seating appointment, the delivery is a slam dunk. So if we go back to Angel and we kind of look at her teeth and we look at the profile view, and you'll notice that there's definitely 3 planes to her teeth. What you may also notice is something kind of looks a little bit odd, is Angel has about 7 millimeters of overjet. She's been through ortho twice, not something that she's going to do again. It's really a jaw issue, but she has a lot of overjet that we maybe typically don't see. She's learned to adapt when she speaks. Obviously, that incisal edge is not going to be hitting the vermilion border of her lip. She has a very reflective surface. The light is bouncing off of those teeth. In contrast, if you have a patient who has a deflective surface, everything's pointing down and away, these are patients that you're going to build those teeth out. You're going to create that reflective surface for them. And it's great. You can do this with a chairside mock-up. You can do it in your wax-up as long as you're giving the lab some specific instructions. When we look at the height to width ratios of teeth, we know that a pleasant width to length ratio is about 80%. Somewhere in that range. I think 78% might be my favorite, but it's a range. It's not dialed in stone. But how do you evaluate that for your patients? What do you look at? I always say the proportions matter. And what I'm showing you is just what's called a proportion gauge. And if I measure the tooth, I just made an adjustment on 9 and 10 in Photoshop just to demonstrate that if we brought the tooth height up to that red line, which matches the red lines on the side, so that puts it in that perfect 80% range, the tooth looks better. So a very simple tool, and you can do this chairside with composite over your patient's tooth so they can visualize what you're doing. For Angel, when I measure her teeth, she's at 94%. She's almost a square. And so what I did was just something in Photoshop just to help me kind of look at her case. I added some length. I changed the gingival tissue slightly, and now that tooth has a more pleasant look to me. And that's at 80%. So now I have an idea of where I want to go with Angel's smile. So when I go to the mouth, I have a better idea of where to go. When I measure the teeth before, and I'm a big fan of using some type of a caliper, I just use an inexpensive digital caliper on every patient. We start at 9.3 millimeters. I'm going to add some length, about a millimeter, 1.3 millimeters to get to 10.5 as far as the length. That's going to put me at that 80% range, and we're instantly going to have a better looking tooth. And obviously, I'm going to balance that with what does she show at rest? How does she function with her teeth? How does it follow her lower lip line? And so this is just a really quick little movie. I do this in Photoshop under the liquify filter. So, if you have a few minutes and you have a photograph and you just want to make some of these changes, you can do this right in front of the patient. This whole process takes about 60 seconds to 2 minutes at the most. And you can really let them see why you want to alter the gingival tissues, why do you need to add length, how many teeth do you need to restore. And you could very quickly make some dramatic changes. This would be a great guide for the lab to use if they're doing a wax up or making your biotemp provisional. When we look at gingival architecture, we know that if the laterals and the centrals, the canines kind of run the same line, that's okay. There's nothing wrong with that, right? It may be preferred to have the laterals slightly lower than the canines and the centrals. That may be a more preferred relationship. But it's never really good to have the laterals at a higher gingival level compared to the centrals or the canines. That never looks good. And so if we just look at a very common case that probably comes in your office, there's a peg lateral, and we want to alter that gingival tissue. In my office, I use an electrosurge to do this, but we're just going to raise that tissue up. We're going to make it more ideal. So now the restorative part becomes fairly easy, and we're going to just restore the case with a couple of veneers and some enamelplasty. So very minimally invasive treatment for our patient, minimally prepping the teeth and getting a really nice result, trying to enhance those gingival tissues. So looking at the pink aesthetics. So we're going to look at one more patient, and if you look at her model, you can see those teeth are overlapped. If you look at the photograph, the straight on picture, you can see the gingival height is lower on number 8. We probably would like to try to correct that. When the biotemp is placed, I did a gingivectomy, and this is my provisional in place, and everything looks lined up pretty good. This happened to be one day before we shut down our offices in Florida, so I didn't see the patient for quite a while. I looked at her just the other day. Her biotemp's now been in for about 2.5 months, still holding up really good, but you can see some of the tissue has rebounded, right? It didn't stay where it was supposed to. And really, I'm going to evaluate it in her full smile. Is that really an issue? Do we need to go in there and maybe remove some bones so we can keep the tissue from migrating back? We decided not to, that we're just going to move forward with the case. When you're talking about soft tissue, you want to isolate where the zenith is and try to get it in an ideal position so it's nice in your provisional phase to really be aware of that. The axial inclination of your teeth, everything kind of goes to the belly button, is a really nice idea and a visual concept you want to have. So if we look at the zenith, when I work on my provisionals, I work really hard in this area so that I can sculpt that tissue, move it to where I want it to be for a better result. So this is a provisional, and you can see I've kind of worked that area between the teeth, and I'm trying to sculpt that tissue, migrate the zenith to where it needs to be. If we look at the same case in the final restorations, you can see those same areas start to look really, really good. And even though number 11, the gingival tissue based on the recession is higher, we didn't graft it, because if we look at the final photograph and her smile, it's not visible. So if it's not visible, I'm not going to go to the extent of trying to fix it and that additional cost for the patient. Teeth proportions, right? The golden proportion, everyone's probably heard of this at some point. It's a mathematical formula. It's kind of it's a guideline. It's not always, and I don't measure golden proportions necessarily when I'm looking at teeth, and there's other proportions that you can go by, but I just want to look at teeth and go, are they proportionate to each other? Do they look like they belong there? And if I just looked at Angel's teeth and I just kind of marked the midlines, and I marked each tooth, they look pretty proportionate. I just kind of drew some lines. These are the same size lines for the centrals. The teeth are almost identical, same for the lateral, and what's visible on the canines is about the same. So I'm not really trying in her case to change that width in any way. I'm focusing on the length. And that's the little length that we added in Photoshop just to see what it would look like. We haven't changed the width at all. In our midline, if you move the midline, if it's off to one side, the patient comes in, you evaluate their smile. These are some really famous studies from Vince Kokich, the orthodontist, that if that midline is off 1, 2, 3 millimeters, to most people, it's not noticeable as long as you don't have a cant. The moment you introduce a cant into the front teeth, it becomes noticeable right away. So midline, and I'll show you some cases right now, but off in some degree are not noticeable. So if we look at a patient, and typically a midline is off because they're missing a tooth somewhere. In this case, our patient was missing number 19. But you can see that the midline's off and the upper midline lowers don't match. We finish the restorations, we do some veneers. This was about 15 years ago. The midline is still off, but there's no cant. And so the midline doesn't become noticeable. So if we look at Marissa and you look at her full smile, you can see that her midline is dramatically off to her right side where she has a missing tooth in the posterior. So that would make sense. But if we look at her final restorations, her midline is still off, right? You can't move a midline very much. You run into some soft tissue problems. So without having to get into ortho to shift everything, it's acceptable to go ahead and restore it as long as the patient's aware of it and you're not adding a cant. And we ended up with a really beautiful smile for Marissa, even though we have a slight midline shift. If we go back to Angel, and one of the reasons I always take these photographs and I mark the midline is for me to know where the midline is and for the lab to know throughout the process where the midline is so that they don't make a mistake. And we always want to look at the incisal edges. It's nice to have them parallel to the interpupillary line. And she has very symmetrical eyes, so this works out nicely. And so a lot of patients, this is Elena, and when I take a bite registration and I use a bite stick, I try to make it horizontal, parallel to the interpupillary line, assuming that the eyes are lined up straight. And in this case, Elena's eyes are nice and straight. I can match that bite stick to my line. I take a photograph just to verify it. Well, what do you do when you have patients and their eyes are not straight, right? And we all have those patients. You look at them and one's sitting a couple of millimeters different and they're not straight. You can use a horizontal, right? So the horizon becomes your new line to line something up with. What I do with a lot of patients, that red line is actually a laser, wall-mounted laser. You just suction cup it to your wall. It shoots a straight line. There's a little level in it so that you know that it's parallel to the horizon. And I match my bite stick to that. And I photograph it just to make sure. Now, it doesn't matter that her eyes would be off because I'm using the horizontal as a reference point. And so in Elena's final case, you can see that we end up with some incisal edges that are very nicely lined up with her eyes. When we look at arch form, a 12 o'clock photo, having the patient tip their head down, really valuable for looking at where those teeth fall on the lower lip, right? If we wanted them to fall on the vermilion border, we could really assess that in these photographs. In the provisionals, we take the photograph to make sure that we have everything dialed in. Now the lab is able to just duplicate what I've already spent time doing in my provisionals. So you can take that type of photo two ways, either the patient's leaning back or they can tip their chin down. So from behind the patient or in front, either way is acceptable. When you look at the arch form of a patient, right, and you kind of evaluate what lines up, you're making some decisions. Are you bringing the molar and the bicuspid out facially to that line? Are you bringing the lateral and the central out to that blue line to correct that arch form? So again, you can do this chairside. You can do chairside mock-up where you're adding to the facial of teeth. And you can really do this instantly for the patient to be able to visualize as you changed an arch form, what it would mean to them. And these are great instructions, again, to be able to give to your lab for your wax up or for your biotemp provisionals. When we look at the occlusal, the posterior plane, right? If we look at Angel's teeth, they are really short, right? And if you look at them close up, we know that we need to lengthen them, right? They don't look like they belong. It's also some gingival changes that need to be made so that we don't look like we have primary teeth back there. But it's going to be a very important part of your smile. And when we look at the buccal corridor, and by buccal corridor, it's the lateral negative space between the posterior teeth and the corner of the mouth when you're smiling, right? So I just did this to give you a little demonstration. If we look at the original picture for Angel, if I took away her back teeth, it's really noticeable to see where the negative space is from that facial aspect of the posterior teeth to the corner of her lips when she's smiling. That's what I refer to as the buccal corridor, is looking at that negative space. But then if I also in Photoshop, I build her buccal corridor out and I can compare it to where Angel was before, I could see that that makes a dramatic difference by bringing those teeth out, right? Not that I wouldn't pick it up right away by looking at it, but this is great information to communicate with your patients and with your laboratory. And so really you want to train your eyes to look at that and not necessarily be focused on those front teeth. We have to move past that so the patient's final product is going to flow nicely when we finish the restorations. When we look at incisal embrasures, we know that they get bigger as you work towards the posterior. We know that the contacts get a little bit smaller. And I think the embrasures are one of those things that you can really do for a patient to individualize their case. And so you can see a diagram of a lot of different embrasures and incisal edges. Really, there's only about 3 or 4 that they're really kind of repetitive and redundant. But when I look at a patient, if you take away the gingival tissue and you just really focus on this area, you can really make that specific for your patient and what they may like. So just a really simple picture of 2 veneers. We only did 8 and 9. We did some enamelplasty on 7 and 10. And we added some incisal embrasure space between 8 and 9, right? Rather than having one that wasn't existent. So a very simple case that everybody has in their office. You can make some dramatic changes. In your provisionals, you really want to work really hard to customize that. If you give the lab that information ahead of time, they're going to be able to do a phenomenal job with your restorations. And along with the incisal embrasure, you want to look at the facial embrasure. And this is just kind of an aesthetic thing when you're doing provisionals. I just wanted to mention it, that if you don't have a really defined facial embrasure, that provisional tends to look like this one, where it's bulky and fat. You see very limited incisal embrasures, facial embrasures, as opposed to this temporary that I showed you earlier, where we have some facial embrasures, incisal embrasures. And so if we look at Angel's case, this is where Angel ended up. And if you think about the things that we talked about, and you look at her incisal edges, you look at her buccal corridor, you'll start to see some of those, how our thought process was. I'm going to work backwards through some of her case and show you some of the steps. You know, when I look at this photograph, I really like the way everything looked out. Should we have made those teeth in the back a little bit taller? Should we have done a little more crown lengthening? Possibly, right? You always can look backwards and, try to improve, and always find things that I'm not overly happy with. When I look at Angel where we started, and I did that little Photoshop to add some length, and I look at the proportions of the teeth that we liked, and we looked at our final restorations, they follow those similar proportions, right? So we were able to kind of keep that throughout the case. When we talked about the facial profile, right, you can see 3 definitive planes on the facial surface, very much like the diagram that we had that we want to be very focused of. But why is it important? Because Angel her incisal edge does not touch her vermilion border. She's accommodated her F and V sounds, and her speech is fine. So why is it important? It's going to be a cosmetic issue, and you're going to see that dramatically when I show you Angel's video. So if we look at it, you can kind of see where we've had a little more display. That incisal edge position looks really nice. When we started this case, we did not do a chairside mock-up. We did a wax-up. I gave the lab some measurements. They returned a wax-up to me. We tried it in with the putty matrix. We did a trial smile. We photographed it. And what I learned from this picture is what I needed to do a little more height in the posterior. And I thought her teeth were a little bit long. I also see on the facial that some of her tooth structure comes through. So we want to reduce that and make room for the material. Angel went through her crown lengthening with my periodontist, Dr. Santana. And then we ordered our provisional, right? The crown lengthening has healed. The gums are healthy. We order a provisional. In this case, I ordered it in sections. And one of the advantages to ordering your biotemp in sections is you can take a very complicated case where you're doing an upper arch, and you can segment it so every step is very predictable. And so the biotemp was made. There's a seating jig to help. And the biotemp is put in on the day of preparation. This is how the patient goes home. And honestly, you can see a dramatic difference. If I showed you her smile and her provisional, you're going to see a dramatic difference. When I said you could segment the case, this is just an example. This is Angel, and this is her crowns 5 through 12 are the permanent restorations on the day that I put them in. Tissue's a little irritated from cleaning up cement. In the posterior, she still has her biotemps. So I'm not messing around with her vertical. I have stops constantly. It's much easier for the lab to mount the models in the lab. It's much easier, less adjustments for me chairside when I'm delivering the case. We measure the case all the way through. If we look at before, we added some length in our provisional. In our final restorations, we have that length that we wanted, right? So very predictable, we're not guessing. If we look at the biotemps, the provisionals, you can see that as a rest, we see teeth. It looks better. We can see in the photograph, one of my favorite pictures of Angel, that you really see more teeth. And if we look in the provisional, I like this photo because when I'm looking at photographs of my patients, and the reason that you take photographs and look at them when the patients leave is, what do I notice right away that most of you are probably looking at? If you look at her full face, if you look at her profile, even though the provisional on the bottom looks great, tissue looks great, it's flared out facially. If we kind of dial it in and look close, it's really flared out. And so from seeing that, I know that when I prepare these teeth, I want to make enough room to have the lab bring in the incisal edge, right? So if we look at Angel before and we look at her after, you can see how we've brought those teeth in slightly. Especially, she's able to hide it really well when she's smiling and when she's laughing. And the posterior teeth kind of flow very naturally with that. This is a video of Angel, and it's just a small clip, but look at that flare of her front teeth and how we were dramatically able to change that just by working in that incisal third and realizing that in our provisionals, we needed to make that correction, right? And that's a life-changing difference for someone. So these are all the things in Angel's case that we looked at, right? We talked about incisal edge and smile line and profile, determining that incisal edge position, the width to height ratios and the gingival architectures and the tooth proportions to make them ideal. The midline, the arch form, and the posterior occlusal plane, evaluating those and using photographs to help you. Looking at the buccal quarter, customizing the incisal embrasures, and ultimately color is going to be part of our microaesthetics. And with that, I am all done today. You can see a close-up of Angel's case. This is my contact information. If anybody had a question you wanted to direct to me, you could do it through Instagram. You can also always email me. I'd be glad to answer you. But thank you for your time today. I appreciate everybody.